Hi, my name's Kathy Frame, and like most of you, I was misdiagnosed. In January, I was told that I had metastatic endometrial cancer, and I had like 2 years to live. I kept saying, what am I going to die from? I'm not sick. There's nothing wrong with me, because I have the non-functional type, so I wasn't sick. So I had the surgery April 7th at Penn by Dr. Fraker, what I call the full Fraker. You know, the tail of the pancreas, the spleen, the gallbladder, the appendix, 14 lymph nodes, 24 cancers out of my liver. And I did really great with the surgery. You know, the surgery's rough, but I did great with the surgery. And then I started to look around and try to decide what to do next. You know, luckily I'm a nurse with a PhD, so I have access to every article that's been written. I have research assistants who are able to research things for me. And it took me to Dr. Fine with his Zalodotemidar study. So just briefly, I want you to know that I've been on 4 rounds of the chemo. I'm a nurse, so I have a very, very busy job. I've not missed 1 minute of work. I've not missed any time from work at all. You're on the Zaloda for 14 days, and you're on the Temidar day 10 to 14. So for 2 weeks, you're on, and I haven't lost my hair. I haven't been nauseous. I haven't thrown up. The only day I'm tired, I would say, is day maybe 4 of the Temidar, but I work all day. I come home, I take a nap for an hour, then I go out and do all my busy stuff I do all night. So it's been a very, very livable regimen. I have several friends now that are on the Zaloda and the Temidar. My brother-in-law is actually on the Zaloda and the Temidar, so we compare stories. But this has been a wonderful, wonderful regimen for me, and it has not really impacted my life at all. I would say sometimes on the Temidar I feel full, like I feel like I just had Thanksgiving dinner and then ate 2 pieces of pie. So, you know, I have to eat tasty cake and pudding and ice cream and things like that so that I get my calories in, which is just so traumatic to me. You know, the other good thing is that I was getting really bad osteoarthritis, and I kept saying to Dawn, who's my research nurse, you know, I couldn't play the piano anymore, I couldn't quilt, now I don't have any pain in my joints. And she's like, well, that's a benefit, it's an anti-inflammatory. So now I'm playing the piano like an hour or 2 a day, I'm quilting again. So I'm not happy that I have the cancer. I'm so grateful that there was a wonderful surgeon for me, and that my treatment has really not affected my life, really in any way at all. So the combination's been wonderful.
Thank you. Yeah. Okay. All right, let me get through some of these questions here. I'm glad that we got done and moved along. I have to thank all of our people today for staying on time. In case you haven't noticed, I think Dr. Kindemi is going to hire me to run his office because we stayed on time. And is there? Yeah, I am a terrible taskmaster. Ask my wife. Okay. All right. Question for Dr. Palmiere. What's the connection between lung and ovary carcinoid tumors? Can you repeat this, please? And there's a mic there in front of you.
Is it on? It is on.
Yep.
I'm not sure I understand the question. We think there are lung primary tumors, and we think there are primary ovarian carcinoid tumors as well. But it's not ringing any bells in terms of there being a connection between the two. Like, is this a patient who has both?
I just read exactly lung.
Oh, I know. Okay, Giuseppe, it's probably about the carcinoid syndrome. So the classic teaching is that, you know, most carcinoids are in the midgut, which means they're in the intestine, and the primary tumor itself, even though it can make the hormones that cause the fibrosis I showed you on the small bowel, doesn't really give the patient carcinoid syndrome. And the reason is that all the hormones that are made locally by the intestinal tumor drain into that vein that goes into the portal vein that goes into the liver, and the liver gets rid of those hormones. So they never make it to the heart and get pumped to the head and neck to cause flushing, and then they don't circulate down to the intestines to cause the flushing and diarrhea. So the theory is you can't really get carcinoid syndrome from your primary intestinal tumor. It has to spread to the liver. And once it's in the liver, now the hormones can drain out of the liver, and the next stop is the heart. So then the heart gets these fresh hormones that have not been cleaned up by the liver, because they came from the liver, and the heart pumps it up to the head and neck, causes flushing, then it washes down and it gets to the intestines, and the intestines respond to these hormones by, you know, secreting and squirming and things. So that's the classic teaching. If you have carcinoid syndrome, you have to have metastatic disease to the liver. But there are 2 important exceptions, and these are things that drain straight back to the heart without going through the liver. So the lung drains right back to the heart. That's because, you know, the blood comes back to the right side of the heart. It doesn't have any oxygen. It gets pumped to the lungs where it picks up oxygen, goes back to the left side of the heart, and then it gets pumped out to the whole body. So if you have a lung carcinoid tumor making hormones, those hormones are going straight back to the heart. There's no liver between the lung tumor and the heart, and so you can get carcinoid syndrome. The ovaries, even though they're in the abdominal cavity, they are not connected to the same veins as the intestines. Rather, those veins drain right back up into the vena cava right below the heart. And so the blood from the ovaries goes around the liver as well. So if you have a carcinoid tumor in the ovary, it can give you carcinoid syndrome without having spread. And so Dr. Warner was presenting a case where he said, you know, here we had a patient who had carcinoid syndrome, look in the liver, you don't see any tumors. You know, that to me, that makes lights go off in my brain saying, look in the lung, look in the ovary. That may be where the tumors are. Do you want to say something, Richard?
Yeah, one more word about ovarian carcinoid. There are, in general, two types. One is primary, it arises there, and it's that kind that can cause carcinoid syndrome without metastases. But the other type of carcinoid in the ovary is metastatic from the bowel, which spreads to the ovary. And of course, in that instance, you would have metastases present. So it's very important to distinguish what we're dealing with if ovarian carcinoid is what's suspected.
Yeah, I find ovarian metastases in patients with liver and abdominal metastases not infrequently. You can see them, they're in there, and we take those out too.
Okay, don't put the mic down. You're next up yet. For Dr. Pommier, can a pancreatic primary be removed and the cancer has become systemic?
That's a question that Michael was alluding to earlier. It's like, gee, do we take out the primary tumors in patients that have really widespread metastases? And generally, we do not for pancreas tumors, unless we can do the liver debulking surgery with it. And the reason is that pancreas surgery is a lot more morbid than bowel surgery. I mean, I quoted the 3 rules of eat now, sleep when you can, and don't mess with the pancreas, but I didn't say why you don't mess with the pancreas. And that's because the pancreas is a really finicky organ. It is a giant digestive gland. So it makes the enzymes in your digestive tract that allow you to break down muscle, blood vessels, fat, and guess what you're made of? So when we cut it and we sew it, it leaks these pancreas enzymes. And it starts digesting things in the back of the abdomen. And it doesn't matter what you try to sew the pancreas to drain it. If you sew it to bowel, it just eats it for lunch. And so the leakage that we get with pancreas is really the number one thing that keeps people in the hospital and gives them long-term complications. And we've tried dozens of things. We tried, you know, glues and staplers, and the pancreas just keeps leaking at the same rate. So, so to undertake pancreas surgery is a very big deal. And we don't want to do it unless we really can get out 90% of the liver disease as well. So I will do them in tandem. If I look at the liver and say, yeah, I can get out 70 to 90%, then I'll do that, and I will take the pancreas primary out. If I can't get out that amount of liver disease, then I don't do it.
Considering that we now have several new drugs that are reasonably effective for pancreatic neuroendocrine tumors, the picture may not be quite as grim for those cases where you have to leave the tumors behind.
Okay, this one reminds me a little bit, and this is a toss-up question. When I took an electronics class years ago, the guy had mugs on the table, and he said, the answer to every question is on the back of the mug. And on the back of the mug, it said, it depends. So, here we go. 5FU with TMZ. Does renal insufficiency preclude this protocol? I'll leave this, who wants to start off on that? Anybody? Dr. Fine?
If you have severe renal insufficiency to the point where you need dialysis, the answer would probably be yes. In that situation, we wouldn't want to do that. But most of the time, if it's only mild to moderate, the dose reduction can be made in the dose of the Xylota so that it's not a problem.
Anybody else have anything to add? Okay.
Let me ask a question of Dr. Fine. Why is severe renal insufficiency a contraindication to those drugs? Can't you just reduce the dose very much? Or is there some other reason? Are they nephrotoxic in themselves?
What happens is the doses will accumulate and do not get dialyzed off completely. So you have no control of knowing, you don't know when the patient's going to have a delayed reaction or delayed GI toxicity. So it's a much more difficult situation. But you can test a patient who's, let's say, on dialysis and test their blood before and after the dose and see if you're able to dialyze most of the drug off. If you can get most of the drug off, then it's okay, but it's a cumbersome thing to do.
Okay. Another toss-up question. What can patients do when years of sandostatin create scar tissue, making injections very difficult? Less and less area where injections are successful. Toss-up. Anybody care to try? Dr. Warner.
Yeah. We can, if you have granuloma formation, in other words, scar tissue at the sites of injection in the gluteus, the backside muscle, we can either try to move the site of the injection a little bit, but after a while we sort of used up all the places we might do the injection. We can try switching over to Lanreotide, which is a drug called somatostatin. It's similar to octreotide, but it's given by a subcutaneous, it's rather a deep sub-Q, but it's a subcutaneous injection, and it doesn't usually cause scar formation. It's not FDA approved for carcinoid or neuroendocrine tumors yet, except for acromegaly, but it's available off-label and can be used and is being used for this purpose in dozens of patients across the country.
In addition to that, we can also give octreotide via pump, a continuous infusion using the same kind of pump diabetics use for insulin. And we can measure the levels and adjust the dose appropriately. And we have all had a few patients that have developed the scarring, and these are a couple of the treatments we have to get around that.
In addition, one of the easier things I think one could do is just switch to, go to the IM injections in the thighs. Both anterior and posterior thigh, that's a large muscle. That would be probably the same drug release kinetics as the gluteus maximus.
Okay. All right. For Dr. Fine also, does it matter how big, they say, I'm guessing large, tumors are to be in this research if the platelet count is low, already around 80, caused by HCTZ? Would you still be considered for this research?
The low platelet count from hydrochlorothiazide, is that the question? Yes. That's usually temporary. All the cases I've ever seen or heard of were always transient decreases and that the platelets should come back up. I've never seen a case where it was permanently suppressed. So if the platelet count should come up within a few weeks once you stop the HCTZ, if that's what the cause is. There's a lot of other causes for low platelet counts that can be investigated and treated very quickly if that's a problem, but that shouldn't stop them from getting the chemotherapy, I think, eventually. Usually we require, and the requirement for the study was 100,000 platelets.
Okay, thank you. One for Dr. Palmier. This is real. Dr. Palmier, will you marry me? Okay. I just had it. Yeah, that one was just good. I had it. I'm sorry. We got to break this up. All right, for Dr. Fine again. He's actually blushing. I don't. It was yeah. Okay. Did you come from Miami? Okay, for Dr. Fine, this is kind of multi-part here. I'm going to try and lump this together. How many days on Xeloda at what dose and how many days on Xeloda and Temodar? Is the Sutent taken on same days or when taking a break from the Xeloda and Temodar? I guess they're looking for kind of like a layout of the dosing regimen for that.
Well, normally it's 14 days of Xeloda, and we can go down on the Xeloda dose to fairly low, actually, and still get the synergy, so that you get maybe a total of 500 milligrams twice a day. It's 1,000 milligrams of Xeloda for 14 days, and then on day 10 through 14, which is 5 days, you start the Temodar twice a day, so it's a total dose divided into an AM and PM dose. And the Sutent, a lot of the work that I showed was all laboratory work, so it's not ready for prime time. I've given it to some patients who have failed. Let's say they responded to the CAPTEM, and then they stopped responding, and we found that we added the Sutent, just 25 milligram tablet, which is lower than the dose that produces all these terrible side effects that were published in the New England Journal article, that the 25 milligram dose was enough for 5 days, once a month, and that was the time that the synergy occurs, because that's when all three drugs are together. And that's what we did. We gave for 5 days Sutent, so that way the Sutent didn't produce any additional side effects, and the patients tolerated it. And what we found in 2 out of 3 people that I've done, 2 of the patients had responses again, and the other third did not. So it's too early, though, to use, I think, without more study.
Okay, for Dr. Warner, this is kind of specific, so I'm going to kind of make it more generic. What's your definition of stable? What do you use to measure stable? Is it MRI, different scans, markers, or whatever?
In clinical trials, nowadays they're using RECIST criteria. In other words, by doing imaging, such as a CT scan or an MRI, it's showing no change in the size of a tumor that's being measured and followed sequentially. That would be the objective evaluation of RECIST. It might be no change in the frequency of bowel movements if we're testing the effect of a drug on carcinoid syndrome. It might be no change in the frequency of flushing episodes, no loss of weight, no change in a person's weight, or some other parameter that can be measured objectively.
I just want to expand on that because this is an issue that, academically interests me very much, this measurement of response or stability or progression using imaging, but also it comes up in the clinic every week, and it becomes, for the patients, a more emotional issue. So Dr. Warner referred to RECIST criteria. Those are very specific criteria that define whether something is stable, better, or worse. And what you're doing is you're looking at your tumors, let's say in the liver on your CT or MRI, and you're measuring the longest diameter, wherever that is. And you can do that on up to 3 tumors that you choose to be your index tumors. Right? So for a tumor to respond, that long diameter, or the sum of the 3, has to shrink by 30%. Right? That's a response. For it to progress, it has to grow by 20%. Anything in between those two is stable. So it's not that it didn't change in size. It means it didn't change by anywhere between plus 20 to minus 30% from where you started. All right, that's the rules. That's what RECIST criteria is. And those rules were created based on very specific studies where they took phantoms with a bunch of balls in them of different sizes, and they scanned them, and then they had a bunch of people measure them. And that's the measurement error. You're measuring the exact same ball, and you have 3 different radiologists measure it from different scans at different times, and the size isn't changing, but they'll measure a variation of plus or minus 20%. That's just the error of the scan. So basically anything in that range is stable, right? That's the definition of stable disease on a CT or an MR. The problem is that in real life, the diagnostic radiologists who are reading your scans don't use those rules. So if they see something that goes from 43 millimeters to 44 millimeters, they'll say it grew, and they'll call it progressive disease, and they'll put that in the report, and it's not. it's stable disease. So you have to be very, very careful because you all read your reports. I know you do. And then you come to the office and you're all upset because, you know, some radiologist said you're worse, and probably you're not. You know, you may actually just be stable. That could just be within the error of measurement from scan to scan. So you have to be very careful and kind of follow the rules on this kind of thing, both from us understanding what we're doing, but also from you understanding what's happening to you, and don't overreact to dictated reports. And that's one of the reasons when I see patients in the office, I tell them, you have to bring me your scans. I cannot, you know, make management plans based on some other radiologist dictated report because it does not tell me what I need to know. I have to see the pictures. And, you know, you always want to get your discs wherever you go.
I wanted to make a comment about that too, because I was one of the investigators in the Radiant trials, which Radiant stood for R80-001, which is now known as everolimus or Afinitor, in advanced neuroendocrine tumors. So Radiant 2 was for carcinoid, and Radiant 3 was for pancreatic neuroendocrine tumors. And when we were designing the trials, we were arguing about what criteria we wanted to use. And we really didn't think rhesus criteria were very applicable to neuroendocrine tumors full of livers, or livers full of neuroendocrine tumors. But we knew that if we just made up a system and we tried to go to the FDA, they wouldn't recognize it. So we decided we were going to go try to jump over the high bar and use rhesus criteria. We had absolutely no problem with that with the pancreatic study. The results between people who took the drug and placebo were dramatic. All the CAT scans got reviewed twice. It's like I, as an investigator, would read them and measure the tumors like Dr. Sulin was describing, write down my numbers, calculate, is it stable, progressing, responding, and send it in. And then another radiologist who is, you know, blinded, that's an interesting concept, a blind radiologist. But the radiologist and I are both blinded. We don't know who's on the drug and who is not. And they read it, and that's where we disagreed in the carcinoid trial. So when it came to the investigators, we got a difference between the patients taking the drug and the placebo. But the radiologists who were reviewing all of our data, they did not get that difference. And you know, we decided that we had to have this certain difference. And you know, just to put some numbers on it, the number we had to have was 0.254 difference between the people taking the placebo and the stuff. We got 0.018. A smaller number is better, meaning that, yeah, there's a big difference. But the radiologist got 0.256, like they missed by 4 1,000ths of a point. And that was enough to kill it. It did not go to the FDA for carcinoid. And I did talk to some of the radiologists when we were getting ready to take the data to the FDA in Florida last April. We were preparing all the data, and some of the radiologists that were these blinded radiologists, they just said, we have no idea how you read these CAT scans. They said, we looked at them and we were confused and we were lost, and we said, which tumors do we measure, which do we not measure? And I, as an investigator, I was jolly careful about it. I mean, I would look at someone's liver and say, I'm not going to measure that tumor because it's too close to another one, and if they grow by a little bit, they're going to merge and look like one giant tumor, when in fact they're two separate tumors. So I tried to pick tumors that are off by themselves wherever possible so there'd be no ambiguity about it. But I have no idea if the radiologists who don't read carcinoid CAT scans in this study did that. And then when I got to Florida, I found out, no, they didn't. They said, we don't read these kinds of CAT scans on a regular basis. So that may be what's really holding this drug up. We're letting the data mature. We're hoping that with more time, perhaps the difference will emerge and we'll just get that other 4 1,000ths of a point we need to get it across the line and get it approved by the FDA for carcinoid.
I wanted to add to that experience that we have really come to appreciate that this disease needs to have special radiology input. In other words, not just any general radiologist, because we'll have a scan done, let's say, by our university at Columbia radiology department, and it's read as tumor has progressed more than 20%. And yet when you look at it, what happened is that the mass broke up into small pieces from the CAPTEM chemotherapy, and it did not progress. It actually got smaller, but because the radiologist saw 3 spots now instead of 1, they read that as progression. So there's going to be a learning curve, I think, for neuroendocrine tumors, including carcinoid, and how to really read these. And you have to be very cautious about who does read it, I don't think there's going to be an easy answer.
I'll just add another caveat just to make it even more confusing and why it's important to look at the pictures. Let's say you presented, for example, with one lesion in your liver and you got whatever treatment and it shrunk dramatically. Maybe it shrunk by 80%. But on that next scan, in addition to seeing that your tumor shrunk, there's a little 1 centimeter new metastasis that appeared that wasn't there before. That's progression. By RECIST criteria, that defines progression. So that'll be read out as you have progressive disease, even though clearly you're much better if you just commonsensically looked at the scan. So, even when people are using the rules, you still have to look at the pictures yourself and apply common sense to you as the individual in sort of, when you're not in a research trial. So there's a certain shaker of salt to be taken with all this response assessment stuff. And another thing that, people sort of make a leap of faith that response matters, that, just because whether you respond or not determines whether you're going to live or die. And there's actually very little evidence that that's true. Many times there are studies done where the people that responded better actually lived less and vice versa. So, it's more important to have disease control, meaning you're not getting worse, than it is to worry about whether you actually responded or not, probably. So.
Another thing that goes along with this, especially for patients that have undergone any interventional procedure, not only do I go over the scan with the one radiologist at my hospital for all of my carcinoid patients, but I go over it with the interventional radiologist because they look at it in a very different fashion than their other radiology colleagues. And there are certain inflammatory changes and so forth that take place that a regular radiologist will look at as progressive disease, that the interventional radiologist goes, oh, wow, what a great response. And these are things that you folks read in the report, and we want to make sure that you guys get the right information. So hopefully you take the things there that you read to us so we can go over it in person. In fact, as my patients know, you don't get a report unless you read with me. That's it. Everything has to be done in person.
We've been talking about evaluating these tumors' responses to treatment for clinical research purposes. But in clinical practice, for handling a patient, we use other additional parameters to determine whether there's stable disease or response or worsening. For example, I put a great deal of emphasis on the markers. If the 5-HIAA goes up, if the blood serotonin goes up, if neuron-specific enolase goes up, that would be a suggestion that we have progressing disease. I have to evaluate that in the context of any symptoms and also in the context of what the scans show. Sometimes there's a great disparity, and then that has to be resolved before you decide on a therapeutic change or action based on these findings.
Okay, thank you. I'm on. Okay, thank you. As you can see, sometimes the simple questions get the most answers. So here's another simple one. Is edema common for carcinoid patients? And what makes it something to be concerned of? In other words, what size, how big, or how, I don't know how she would evaluate it. They say your palm size area on the leg before you would do anything with it.
Well, certainly for surgery it is. We get, I would be concerned about carcinoid heart disease if there's edema, and I'd want to make sure that's ruled out with an echocardiogram. I get an echocardiogram on everybody before I operate on them if they have liver tumors, because even if they don't have edema and they're not short of breath and they don't, have the usual problems with congestive heart failure, sometimes they have subclinical congestive heart failure that's going to matter in the middle of a liver resection. That's a very, very bad time to find out you actually have subclinical carcinoid heart disease. So beyond that, I don't know that it's much of a problem. Richard?
There are a variety of causes for edema in the lower extremities in not just carcinoid, but other neuroendocrine tumors. For example, we may have deep vein thrombosis. This certainly has to be considered. We may also have pelvic tumor masses, compressing the venous and lymphatic return from the lower extremities. So that has to be evaluated too, along with the possibility of carcinoid heart disease. We may have a very low blood albumin level because of malnutrition, and that ends up causing edema in the lower extremities. All of these must be considered.
Yeah, one of the compressions is what's called inferior vena cava syndrome. So the vena cava, the big vein that takes all the blood back from the lower half of the body, goes through the liver on the way back to the heart. And if there's enough liver tumor, it will crush the vena cava. And then people get edema from basically from the belly button on down. And it can be relieved by people like Dr. Sulin. They can go in and put a stent in and open that up with a big stent the size of a toilet paper roll, and it goes away.
I want to see that stent.
I prefer the hot dog analogy.
Okay. How is a patient's quality of life affected when they receive chemoembolization?
Well, okay, so if you do chemoembolization, the 90% of patients gets what's called post-embolization syndrome. So if you cut off the blood flow to a solid organ, and it could be the liver, it could be the spleen, it could be a kidney, it could be the uterus for women having fibroid embolizations, it hurts, it makes you sick to your stomach, you get a fever, you get an inflammatory reaction, you'd have elevation of your white blood cell count if I looked, which I don't. And with liver embolizations and kidney embolizations and spleens and uteri, we basically advise you at least one night in the hospital on IV anti-nausea medicines and IV pain medicine. Most people are over that overnight and are ready to go home sometime the next day. Some people, it's 2 days. Once you go home, you're over the worst of it. Most people have fatigue and loss of appetite that lasts for a couple weeks after the procedure, which correlates with the period of biochemical liver dysfunction. So although the liver tolerates being embolized, it doesn't like it. If I actually measured your liver enzymes after an embolization, you'd see them spike way up and peak at 3 to 5 days and come back down to normal at 10 to 14 days. Surprisingly, that correlates exactly with when people feel tired and not hungry afterward. And then by about week 3, you start getting your starch back. Also, you do get some systemic effect from the chemo that leaks out of the liver, so there is some usually mild drop in blood counts, which will bottom out around 2 to 3 weeks and it's on the way back up by 4 weeks. So that's why I say that most people are kind of ready for their next chemoembolization about 4 weeks later. You may not be perfect, but you're kind of on the mend enough to do it again. If we do 2 or 3 of these in a row, though, you may feel pretty beaten up by the last one, and you may get a little anemic at that point. But that's a very, very typical course with chemoembolization. If you do yttrium, the radioactive bead embolization, that's much gentler. Half of people have no side effects at all. They come back a month later and don't even know you did anything to them. About 30 to 40% get radiation-related fatigue, about 10% get radiation-related nausea, and only a very small percentage get anything more severe like pain or fevers or vomiting. So those are the big differences between the two. And, there's a range for every person. Some people sail through this and go back to work the next day. I'm talking about chemoembolization. Some people feel so lousy a month later they're not ready for the next one. But most people fall somewhere in the spectrum I described.
Okay. Kind of a general one. How do you suggest putting together a multidisciplinary team of your own at a center that is the one center that is accessible to you? I thought this was a simple one. Not really.
It comes down to speaking to whichever physician you start with, be it your surgeon, your medical oncologist, your gastroenterologist. You have to find somebody that wants to be your champion for that disease and bring together a willing group of people that want to care for you. Be it from an endocrine point of view, cardiology, pulmonary, and everybody that's here has invested time. That's what it comes down to. You have to invest time and effort, plain and simple.
Okay, thank you. Can chemoembolization shrink a tumor in the mesentery? I can't even talk today. Any other organ other than the liver if there's good access to its blood supply?
Okay, so there are two organs in the body that have a dual blood supply, the liver and the lung. So those are the two organs where you can catheterize the artery and occlude it, and the organ will survive because the liver is fed mostly by the portal veins and the lungs by pulmonary arteries as opposed to bronchial arteries. So we can chemoembolize tumors in those two organs. Everything else in your body just has arteries. So you have to be very, very careful when you start catheterizing and occluding those because you have to try to just chip off the tumor and not occlude any blood vessels to the rest of the organ if you want to keep it alive. So for example, we commonly embolize kidney cancers because kidney cancers, when you get out into the arteries to the kidney, have a very distinct tumor blood supply that's separate from the arteries to the normal kidney, and we can selectively catheterize those and embolize just the tumor and leave the rest of the kidney alone. You can embolize the uterus because the fibroids die and the uterus doesn't. Once you start getting to things like the mesentery, though, it gets awful tricky because those tumors growing in the mesentery are fed by the same branches that feed the bowel. And if you start embolizing branches to the bowel will perforate and die, and you'll end up with emergency surgery. So I've done it on very rare occasions. You have to be able to absolutely identify little tiny branches that go only to the tumor and aren't feeding bowel and be sure that's the case. So that usually means you have to do a combined angio-CT to be sure that when you inject contrast in that artery, you don't see any bowel lighting up. It's very tricky. And, you know, I can't think of any great reasons to try to do that, frankly. I'd much rather send someone to surgery to have that taken out or just leave it alone. I think that's doing something in the mesentery would be incredibly risky.
Okay, thank you. I like people who are educated. Dr. Fine, in your studies, you had patients that, quote, failed sandostatin therapy, unquote. What does that mean, and how do you measure that? Were they somatostatin negative? And then the last one is, who's funding your study?
Well, when I say sandostatin failures, that meant that their tumor progressed, grew more than 20%. On high-dose sandostatin, and that's 60 milligrams. So it's 30 milligrams, 2 shots every month. And if they progress on that with a 20% increase in tumor, then that was the criteria that we have for getting into the study. What was the second part?
Funding. Who's funding the study?
The study was funded by what's called investigator-initiated program that Sharing Plow, which is now I think Merck, initiated. That you write a grant, you write a proposal into them, and if they like it, they support it with money to pay for the Temodar. So the Temodar was given free, and the Xeloda was free as well because that's covered in under neuroendocrine ICD codes. So the patients just came for their visits, and they funded the visits as well. But it's a typical study, and from what I understand, the drug Temodar is coming off of patent in August of 2012, and the company is not interested in doing any more studies with Temodar because of it, and they told us recently that they want to cut the funding to our study, even though the results are so phenomenal, because they want to start saving their money for other things. So we need a grassroots action, essentially, to get Temodar approved for this disease.
Okay, patient here, I have carcinoid syndrome, and when I drink alcohol, I flush. I take sandostatin. If I have Sursphere's liver treatment, will I be able to drink after the Surspheres?
Yes.
Quality of life? It's a quality of life question here. Okay, this kind of ties in a little bit because I'm going to add a couple words in here to clarify something. Is there any correlation between lung carcinoid and non-alcoholic fatty liver? And I guess for those who don't know, what is non-alcoholic fatty liver?
NASH, N-A-S-H, is non-alcoholic fatty liver. And to my knowledge, there is no correlation.
Okay, changing to a new lab, they do not use boric acid in a 5-HIA collection container. They said it's okay. Is it?
Yes, it depends upon the technique that is used in the assay. Some labs do an assay in which that preservative is necessary, others don't. But the lab will stipulate what is required for preserving the urine properly. Main thing is to prevent it from getting heated. It's best to be kept during the 24-hour collection in a refrigerator, or at least where it's cool, not at room temperature or not where it's heated.
Oh, I have so many apple juice jokes to grow with that. But I'm going to behave. No, I won't. Did I hear correctly? Taking up to 60 milligrams of LAR is okay, but nothing higher is of any help. I think that was part of your lecture.
No, Robert said that.
Oh, Robert? Dr. Fine? I'm sorry.
Well, it was my understanding that there were a few studies done about 10 years ago showing that the receptors that sandostatin binds to, particularly the receptor 2 and 5 subtypes, are saturated when you go to 60 milligrams once a month in most people even with large volume tumors. And so we thought, if the tumors at 30 were not saturated with these, with the sandostatin, then perhaps you weren't getting maximal anti-proliferative inhibition or causing the tumor. Sometimes the tumors will even shrink with sandostatin. It's not very common, but it does happen. It's more common that they'll become static. So that was the reason why we decided to go up to 60. I think in retrospect, we sort of made it much more difficult for ourselves, because when patients already have failed 60 milligrams, that means they've had it for a long time and are not in the most pristine conditions many times. And I think the next study will probably try to skip that requirement so that we can get more people. Now, if you're one of the 20% of patients who have octreotide negative disease, octreotide scan negative disease, you can go right on to the chemotherapy. We didn't have any requirement for sandostatin. It doesn't make any sense anyway. We had no requirement for sandostatin failure.
If you're quoting like Gene Waltering's and Aaron Vinnick's study, that's a study where we drew blood levels on patients taking 20, 30, 40, and 60. And it's a theoretical thing that Gene Waltering has done in his lab. He basically said that the somatostatin receptor has a thing called a binding affinity, which means how much does somatostatin want to bind to it. And he basically said that that's a number known as Ka. And to get 99% saturation of the receptor, you have to go 10 times Ka. So he basically said, do people make it to that 10 times Ka on 10, 20, 30, 40, and 60? And really what we found in the study was that the blood levels were really tight. There wasn't much variation in the blood levels of people taking 10. It was a little bit more in people taking 20, a little bit more in people taking 30. But when we got up to people taking 40 and 60, the blood levels were all over the map. So the only people that even had a prayer of getting up to that 10 times level were about half of the people taking 60. But some of the people that were taking 60 a month had really low blood levels. So it seems like the higher the dose, the more variation we seem to get in the blood levels. And again, the 10 times thing was just kind of made up by Dr. Waltering.
I remind you, this is going to be on video on no. Gene will be calling.
Gene calls me anyway.
Is there a correlation between carcinoid cancer and other incidences of cancers, including neuroendocrines or other neuroendocrines?
There is an increased frequency of metachronous cancers of a variety of types with carcinoid, particularly in men, colon and prostate, and in women, colon and breast. In fact, some studies have shown that at some time during their lives, a patient with carcinoid has about a 25% chance of getting another cancer. This is why one of the things that should be done is an annual mammography on a woman, and also colonoscopies at appropriate periods. especially if there's a family history or a past history of, say, of colon polyps.
Okay. If you've had a chemoembolization done and they damaged your bile duct, can you eventually get another one?
I mean, in theory, yes. You know, the bile ducts, as I mentioned, have an end arterial blood supply just like the tumors do, so you always get microscopic bile duct injury when you do a chemoembolization, which usually is clinically silent. But every now and then, a few percent of the time, you'll get significant bile duct injury. That doesn't mean you can't get it again, although in that, to a different part of your liver, let's say the other lobe, but it would probably be somewhat risky in the lobe that you had treated. One thing I should probably throw in, actually, is a good setup for this. One of the more recent innovations in chemoembolization has been drugeluting beads. Some of you may have heard about these. Called DC or LC beads that are available in the U.S. market now. There's another one called Hepasphere or Quadrisphere, where the chemotherapy drugs, instead of being emulsified with oil, are actually loaded onto the embolic particles. And two huge series just came out this year, specifically using them in neuroendocrine patients, showing a greater than 50% rate of liver necrosis with drug-eluting beads in patients who were chemoembolized who had neuroendocrine tumors. So I would stay away from anyone who's offering you that. It's not approved in the U.S. As a drug-loaded bead, but they're sold unloaded off-label, and then the physicians load them themselves. So it's pretty readily available around it, and I would discourage people from that, mostly hepatobiliary injury.
Okay. Does pasriotide have to be injected deep tissue like sandostatin LAR?
The answer is yes.
That's simple. Dr. Warner, how is the experiment with Notch 1 progressing? Is there any further research involving the eradication of carcinoid on a genetic level?
That project is still in progress, being carried out in University of Wisconsin by Herbert Chen's group, and studying that metabolic pathway for growth of tumors is still being evaluated.
Okay, Dr. Warner, you may want this one also, or at least to start with. Is it ever possible to revisit a chemo that was discontinued due to progression of disease or inability to tolerate?
Yes, it is, depending upon what the chemo is and why it was discontinued. I think that Dr. Fine may want to elaborate more on that.
Dr. Warner's correct. Many times you can go back to a chemotherapy regimen that's slightly different schedule, even if it's the same drugs, and the different schedule may sometimes allow you to have a response. Or using congeners of those drugs, in other words, not exactly the same drugs, but drugs that are similar to it, may get responses as well. Like I've had some patients who, once they fail temozolomide, they'll respond to BCNU or CCNU, which are also very old drugs used to treat brain tumors, lipophilic alkylators. So the answer is there's always a possibility. It just sometimes it requires thinking outside of the box and doing something that's a little unorthodox.
I agree with those comments. And this is what it comes back to from what I said before. Everything has to be customized to the particular patient. Sometimes for instance, our chemotherapies, the way we use them nowadays, we have a maximally tolerated dose and say, okay, this is generally where we start. During our lunchtime, I was speaking to Dr. Fine. If you give too much chemo, it's hard to take it back. You can always add more. So with some of the regimens, I take an educated guess as to how much we can start with, and hopefully it's a pretty good guess and move on up. But sometimes it's a guess that was inaccurate. Even though it was something that was dose reduced, it was still too much, and we might wind up having delays in treatment because of toxicities, and then when you have progression of disease, sometimes after a washout period and letting the bone marrow recover and the rest of the body recover, you reintroduce the drug in a different fashion, and we're able, hopefully, to get a response. So you just have to keep your mind open to what can be done.
Okay, this one should open up a real nice can of worms from different sides and different viewpoints. What is the value of taking chemo, Xeloda, etc., if tumors in the liver are clearly operable and the patient's willing to get surgery? No takers.
My feeling is if they are surgically operable, that should be done first. I would like to hear a comment from Dr. Fine as to any relationship between the size of tumors and response to chemotherapy, since to my knowledge, the dose that's determined to be given is not so much based on the size of tumors or the tumor burden, but rather on the patient's weight and size.
The dosage of chemotherapy that's given, in my experience with the retrospective study and the prospective study that we're doing now, the response of the masses did not correlate with how big they were. In other words, we saw responses in something that was 2 centimeters and 12 centimeters, and it didn't seem to really matter what size the mass was. So that, an answer to that question. But I think that, if you have something that is clearly operable and it's still, if it's a large mass, there's a very high likelihood that the tumors will come back. I think in neuroendocrine tumors, in my experience, and maybe I'm wrong, 90% of the patients who undergo surgery have tumor recurrence. And I'm wondering if anyone has ever studied, why not give neoadjuvant chemotherapy first to shrink them as much as possible and then remove them to see if, and then give adjuvant chemotherapy after surgery, just like we're moving towards in pancreatic adenocarcinomas, to get long-term survivals. And maybe that would be something we should be thought about more often.
I agree wholeheartedly with that, and in fact, this is something that I've brought to my carcinoid and neuroendocrine tumor practice from experience we've gained in predominantly in breast cancer. The most important thing we do in that setting, by even giving the somatostatin or Temdar and Xeloda, is that we have an in vivo test. If you respond, we know you respond. And this is something that we can use after surgery, where we have a complete debulking, hopefully, and we can give adjuvant treatment, adjuvant meaning after surgery. Many times patients come to us after colon cancer, after breast cancer, after lung cancer. Okay, I have stage 2 disease, I have stage 3 disease. This is the standard of care regimen now. This is the chemotherapy I have to give you, as long as you meet all the criteria for it. I have no idea if that's the right chemotherapy for you. I don't know if your particular tumor is going to work. But if we have a target lesion in the liver that we can measure, we go through several months of somatostatin or several cycles of Temdar and Xeloda, and it shrank by 50%, I know we have the right chemo. And that's a perfect test for an individual patient. So I'm very much in favor of this neoadjuvant, meaning before surgery treatment.
I am too. As I mentioned toward the end of my lecture, is that we've had a few patients who they've come to see me, and I said, you're just really marginal or over the line for surgical debulking, but you can get chemotherapy first, and we've had these patients get responses that have been adequate enough that we can go back and operate. And yes, it's the vast majority of patients who get a complete resection, and as I said, that's a very small percentage of patients with neuroendocrine tumors that can have all their liver tumors removed. They overwhelmingly recur over time. They get more tumors, and that's one reason why insisting on complete resection is just silly, because the vast majority of patients they'll get another tumor anyway, and the patients in whom we leave tumors in do just as well as the ones that we get complete tumors out of. So I think that's definitely the direction we need to move, is to try to get more patients to surgery by treating them first. That was a huge paradigm shift in breast cancer. There's an entity known as inflammatory breast cancer that was inoperable when I started medical school and residency. And then, it still is. You're right. You don't ever operate on inflammatory cancer. You treat it with chemotherapy first. And then when it gets better, then you operate. And it took an unsurvivable disease and made it, to the point where we can get some long-term survivors. And I would certainly love to have help after surgery where we get a good debulking to keep it that way with drugs.
Another comment regarding the use of chemotherapy prior to cytoreductive therapy. I know there have been studies in progress for the administration of chemotherapy in hopes that it will be, or an evaluation of its sensitizing the tumor to radiation so that it would enhance the effectiveness of radioemboli. Perhaps Dr. Sulin can comment more about what's going on in that regard.
It's funny because Dr. Fine and I just had that conversation as to whether that would happen. And he could probably answer the question better than I can, because there are certain systemic drugs that are known to sensitize some tumors to the responsiveness to radiation, and one of which is the class of drugs to which Xeloda belongs. So one of the questions I actually had asked Dr. Fine is, for a slow-growing tumor like neuroendocrine tumors, which aren't typically things we think of as being normally that radiosensitive, did he think that giving a drug like Xeloda might actually enhance the response to a sursphere therapy? I'll let him answer the question.
Yeah. Thank you. We're all of us are sort of up here with a lot of BSing around, I guess, but I mean, it's a guess. It's a medical guess. But what I would like to see would be a situation where we took the principles of CAP-10 pharmacology and put it into a situation where Dr. Sulin works, so that the patient would take, say, 10 days or 14 days of low-dose Xeloda, and then the patient would get through the interventional radiology, the administration of the Temodar, which could be DTIC, same type of drug, right into the tumor bed of the blood supply, and that would be utilizing the best of the chemotherapy that we have as a way of killing tumors by chemoembolization, and then sort of block the exit of the drugs with foam or whatever that they use. But that would be a very nice study, and that would see if we could improve the results of these studies. But again, my plea is that we got to do these things prospectively in a study, and there's too many of us. There's not enough experts out there, and the few of us that are here, we need to work together more. We really do. I think that this, again, the retrospective studies are nice, but they're not sufficient, really, to push this field forward, to know what to do definitively.
Regarding chemotherapy versus surgery as the first undertaking in treatment, I'm a strong advocate for molecular profiling of the tumors so as to have a little more information to help make the choice of chemotherapy. And to do this, you need to have tumor tissue. Consequently, that would favor earlier surgery before choosing chemotherapy. For example, you heard about MGMT as an enzyme that can be measured in a tumor, and its presence or absence helps to determine the likelihood of an effective response to temozolomide. And of course, tumor tissue can be assayed for that, as well as for many other indicators which can help in the choice of chemotherapy.
I love stirring the kettle. Actually, my point really is we have different disciplines up here and different viewpoints. And you know what? None of those answers is wrong. And that's the great thing about having this panel up here.
Actually, Dr. Warner brought something up that's very important. I think we are moving definitely much more towards personalized molecular medicine, where your tumor type is going to be characterized and the decisions will be based upon that. And that's happening now, and it's going to happen more in the future. But there's something very fundamental that bothers me about this, and that is we've went from a period, I'd say 20, 30 years ago, where we would biopsy tumors. Now we don't biopsy tissue anymore. And when he was talking about The problem is you have to get tissue before surgery to test or before you decide what you want to do. I really think it's imperative to tell the public that when they get their tumor diagnosed, that you ask them to do a core skinny needle biopsy, which gets a thin ribbon of tissue. That tissue will be useful for the rest of your life with that cancer. In other words, if they just do a FNA, a fine needle aspiration, you can't do any of these tests whatsoever with a few cells, a couple hundred cells. A fine needle aspiration is now being done virtually all the time in all the different tumor types. And it'll save you, I think, a lot. It'll give you a lot better starting point to be able to, if they could biopsy and get real tissue, and then you could do this type of studies that Dr. Warner mentioned, and it could be in the future for other things as well.
On a practical note, as in keeping with what you just heard, archived tumor tissue that's preserved in a paraffin block and has been fixed, which is now required by all pathology departments across the country, is available on any tumor that you've had resected, and it is still good for several years to be utilized for this molecular profiling. So we can go back and get that tissue for this purpose. Not if it's too many years old, it loses its ability to be properly analyzed, but a couple of years, it's still good.
Okay. Is there any evidence that high levels of stress can lead to progressive disease in carcinoids?
Not that I'm aware of, excepting that your blood metanephrines, things like adrenaline, will be a bit higher and may be provocative if you have carcinoid, but we don't know that it provokes the growth of the tumor, but simply its endocrine function.
I've never met a carcinoid patient who didn't have a high level of stress, so I have nothing to compare it to.
How true. How do you get a baseline? Okay, for Dr. Fine, I've been on Cap-10 for a number of years. With taking my Temodar only at night, would you recommend adding Sutent to my regimen?
I'm assuming that whoever this person is stable, and they must be doing well, and that's why they are continuing on the treatment. I would not add Sutent for sure, number one. And number two, I wouldn't divide my dose into 2 doses unless you still have a lot of nausea from the once-a-day dosage. I would just keep it the way it is because everything right now is stable, and hopefully that'll go on. As I said before, our longest patient on our prospective trial is over 5 years, and he's had 75% shrinkage of his massive liver metastases over that time. So I wouldn't change it. If they're doing well, just keep it the way it is.
Okay, I got time for a couple of more here. Please clarify, is embolization, either chemo or radiofrequency, possible on tumors scattered on surface of the liver?
And the answer is yes. One thing that's a concept that's important to keep in mind when you're doing embol therapy is that it's a plumbing-based therapy. We're not aiming for this tumor or that tumor. If we catheterize the artery, the right lobe of the liver, we embolize every tumor in the right lobe. If we do the left hepatic artery, we get every tumor in the left lobe. So it's a purely plumbing-based therapy, and you get every tumor in that territory.
Okay, this is somebody who probably went to our last conference. Is there any current research or interest in interferon as a viable treatment in the United States?
Yeah, we have one trial open that's combining interferon with another chemotherapy agent, and it's open for enrollment for patients who have progressive disease.
Okay, can you clarify the difference between functioning and non-functioning? What's the significance of the difference?
Functioning means having clinical syndrome, clinical symptoms because of the production of excessive amounts of some hormonal substance by a tumor. Non-functioning means not having clinical symptoms because of excessive hormone production. That doesn't mean that there won't be measurable amounts in the blood. It just means that there won't be extremely high levels.
Significance?
Well, the significance is that you have extra symptoms added to the symptoms of the growth of a tumor. You may have, for example, heart failure due to the effect of serotonin on the heart. You may have bronchospasm with asthma-like symptoms due to the effect of serotonin and also bradykinin, which are hormones or substances produced by the tumor. These, in addition to the symptoms that might come from the mechanical, physical presence of the tumor. But if we control those symptoms, then you have only half the problem.
I tell patients with functional tumors we have to fight two battles. One battle against the hormone and its symptoms, whether that's flushing and diarrhea from carcinoid or low blood sugar from an insulinoma or acid and ulcers and bleeding from gastrin, and the cancer war in terms of the cancer spreading and taking over the liver and causing the death of the patient. And you can lose on both fronts. It's like before we ever had octreotide, most carcinoid patients who died literally died of diarrhea. They might as well have been living in London in 1854 during the cholera epidemic because you just couldn't keep up with the fluid and electrolyte losses. And autopsies done on those patients showed that their livers were still pretty good. They didn't have a lot of liver replacement. And now we can stave the diarrhea off almost indefinitely. And so that shifted it so that, it's becoming an oncological war, fighting the cancer spread. But the non-functional patients fight one battle.
Okay, last question. What is the role of PRRT in supplanting chemo as first-line therapy, and what's happening in the US with PRRT clinical trials?
Well, first of all, there are 2 centers in the United States where clinical trials of systemic radiotherapy, internal radiotherapy has been approved. It's just newly approved. One is down in Houston, and one is at Tom Odericio's Center in Iowa, at Iowa State. Both of these are clinical trials and entail the use of lutetium-177. These radioisotope drugs are quite effective in patients who have trioscan positive tumors, because the features of the tumor, the avidity for these somatostatin analogs is the same as for the radioisotope medication, and so it attracts this preparation to the tumors, where it concentrates and gives intense internal radiation. However, usually there has been, it's reserved for advanced cases because it requires several courses of treatment and has a risk of bone marrow depression and also causing renal problems. And very often, once you do these treatments, you can't go back to any other kind of chemotherapy. That may change as we go along, but right now we're still in the course of getting approval for this line of treatment in the United States.
So there is one form of PRT therapy that is available in the U.S. Now, none of the octreotide products are available except on these 2 trials, but there's another compound called MIBG, which is avidly taken up by neuroendocrine tumors that come from the adrenal gland and some other areas, not typically the GI and pancreatic origin ones, but as it turns out, about half or more of patients with gastropancreatic neuroendocrine tumors take up MIBG. So the ion MIBG is iodine, so there's a diagnostic scan with minimally radioactive iodine to determine if your tumor takes up MIBG, and then you can get I-131 MIBG therapy, which we do a lot of for people with adrenal tumors and some other types of cancers. It's completely off-label use, but it's a legally available therapy if you're eligible, and the biggest problem is getting it paid for.
Okay, gentlemen, thank you so very much. I got to thank a bunch of people here. I mean, Judy, Mike, Jill, Phyllis, my wife, Tom, Kathy, other people I'm forgetting, Kristen and everybody else. Novartis for their support of this, all of our volunteers for this. We've got still some tote bags, hats, and pins out in the lobby. Yeah, I'm pushing. We don't make a lot of money on them, but you know what? It's more of us really to get the word out there. If you're seen with this, somebody says, "What's Carso? What?" Okay. So that's kind of what we do. Please do not forget your feedback surveys. Again, I say I really know I'm a pain in the butt, but your data info sheets and feedback surveys in the box outside, or I'll leave a box up here for you. I do want to thank each of the doctors here for giving up their Saturday, their family time. And especially their willingness to share this. This is just so amazing what we can do here. I want to thank each of you for choosing to be here and your time here today to further your knowledge. And we hope we met your expectations. Everybody have a safe travel. Thanks for coming. We hope to see you at the next one.